one and all. Once again, I take pleasure in extending a warm welcome to every one of you to OATN IT's platform. It's an honor to have our speaker to Dr. SKR, a well-known ophthalmologist and our favorite chair too. And we also have Mrs. Ranjan Madhavan to moderate the session. Complete BS in optometry at Telate School 1919 and she's Shankar Netralia Essence. She's had various departments of Shankar Netralia till late, including like and MR and also had optometry. Currently, she heads training for optometrists, all fellows, DO and NB, FRCS refresher in nursing. She has played a major role in the development of CVS clinic of SN. She is also currently pursuing PhD. Apart from participating and conducting workshops, symposiums, and conferences, her study on myopia, vision therapy, better interpretation, and presentation on autumn have won awards. Proudly present Mrs. Ranjani Madhavan is our moderator, and we wish her more accolades here too. Oh, ma'am.
Thank you, madam. Am I audible?
Yes, ma'am. I think it.
Okay, so that brings mastery in any field he chooses, and his choices, best performances in his MBBS degree in 1987. After Rio in 1991, he joined Shankar Netralia and was loved for his patient care, beautiful surgeries, and of course, his lovely classes. During those very years, he earned his DNB and the prestigious FRCS Edinburgh, and mind you, both in the same year, 2002, another feather in his cap, best performer in the FRCS exam. In 2004, he resigned from Shankar Netralia as Senior Consultant Cornea Services and Director of International Relations to join as a professor in the Department of Ophthalmology and Visual Science, Chinese University of Hong Kong. Visiting professor in Hong Kong and China. His specializations. I think I lost you in between. Lamellar corneal surgery, keratoprosthesis, advanced IOL surgery, epidemiology and biostatistics, you name it. He masters it from wherever he is in the world that he can learn it best. He has attended 277 national and 72 international conferences, delivered more than 633 lectures, more than 191 peer-reviewed publications to his credit, 20 book chapters, and umpteen research projects. Now, if Alcon, Allergan, Cipla have a phase 3 trial, he is the principal investigator. He is the section editor for anterior segment clinical and experimental ophthalmology and a reviewer for 10 international journals. He is a member of the International Steering Committee for MOOKP Surgery and is the president of the Cornea Society of India. I could go on and on, but I wouldn't keep you away from his session any longer. Over to Dr. Srinivas K. Rao.
Thank you, Ma. Thank you for that introduction. I'm just going to share the screen. I think the net's a bit wonky, so let's just hope that I'm audible and that you can see my screen. Is the slide visible and am I audible?
Yes, sir. Yes, sir.
Okay, so then I'm going to start. So good evening and thank you for the invitation to be here at your optometric meeting today. Many of you are old friends, and I think there'll be some others who will be joining whom I probably will be meeting for the first time, and to them I say welcome. And let me start by wishing all of you the very best of health in these difficult times that we are facing at the moment. As you can see, I have kind of modified the title that Balaji had given me. And basically, he said he wanted the diagnosis, referral criteria, and the co management guidelines for dry eye disease. I've just changed it to guidelines instead of criterion. And I'm going to just tell you why I did that in a moment. So basically, whenever we talk about a condition, we need to know what we are looking at. And dry eye disease, this is the most recent definition that the DUCE 2 has given us. And as you can see, it's a fairly complex diagnosis. There are multiple factors that make it up. So we are talking about a multifactorial disease of the ocular surface. So right in the beginning, we are not saying tear film. We're talking about the ocular surface. And I'd like you to take one point home today. And this is the point that we're talking about the ocular surface as a whole and not just as the tear film. So what we have as a problem here is a loss of homeostasis of the tear film. And this is accompanied by ocular symptoms, which is what brings the patient to us. And in these symptoms, tear film instability and hyperosmolarity play key roles. These result in inflammation of the ocular surface and ensuing damage. And the most recent addition in the last definition has been the recognition of the role of neurosensory abnormalities in this particular context. So what I'd like to do is basically spend about 10 minutes in the beginning of this talk. I was given about 45 minutes trying to talk about dry eye disease in the context of ocular surface disease, trying to help you understand the difference between the two and how you should look at the patient holistically and not just as the tear film alone. Once we do that, we then come to the actual diagnosis, and this is defined as the identification of the nature of an illness or problem by examination of the symptoms. So essentially, in ancient medicine, patient came, gave you some symptoms, and then you tried to make out what was wrong with him. In the context of dry eye disease, we will add signs that you pick up when you examine the patient and the eye, and the tests that you do and the results of these, and how can you put all this together to come up with a diagnosis. And this is obviously the most important part. Unless you make a correct diagnosis, you can't treat a disease, and therefore we will spend about 30 minutes on this. Now, what we wanted was criterion for co-management and referral. The criterion is defined as a principle or standard by which something may be judged or decided. So let me give you an example. So when we talk about LASIK, who can have LASIK surgery, we have an age cutoff of 18. So for me, this is a very hard and fast rule. It's a yes or no response. If the patient's 17, no LASIK. If he's more than 18, then I will consider LASIK. Of course, there are other criteria that I will use to judge whether I will do LASIK for him or not. So a criterion is a fairly hard quantity. It's a hard stop. Basically, it allows you to divide on one side or the other, yes or no. Less than 18, no LASIK. More than 18, possibly LASIK. But here, when we talk about referring a patient to a doctor or an ophthalmologist as an optometrist, I don't think we have criteria today. We don't have any hard rules that I can give you and say, okay, if this is this, immediately send the patient off. And this will also depend upon the experience of the optometrist. So if you've been doing this for 10 years, as most of you probably have been, you're quite capable of managing a vast majority of these patients. And therefore, your guidelines or index for referring it to another ophthalmologist would be a lot lower, as opposed to somebody who's just starting, who needs to pick up a little more experience. So they may refer the patient earlier in the disease. Therefore, I took the liberty of changing this to guidelines. A guideline is a general rule, principle, or a piece of advice. So basically, if you take a Shermer, we generally think 16 is a cutoff, and anything less than 16 is possibly abnormal, more than 16 or something like that. But it doesn't mean that if you're seeing a patient in your clinic and if he has a Shermer of 15, you say, this is dry eye, I'm going to refer it to somebody. So there will be other factors that you will put into the mix before you make a final call. And therefore, this is a little more of a soft stop, not a hard stop. So we have guidelines. There will be certain indicators that I will try and share with you where I think you may be best advised to seek the counsel of an ophthalmologist. But this will happen after you've done most of it yourself, 75% or so, and then we will see what those are. And finally, of course, this is co-management. I think that's eminently possible. I think I'm already doing it with a lot of my optometric friends and colleagues. So a lot of them send patients. We then manage them jointly. And I'll tell you what those principles that the guidelines are regarding that as well. So the problem with the tear film is that when we talk about the definition, it's already a fairly complex thing, as you saw. It's not a very straightforward thing. And if you look at this particular picture, this is a picture of the ocular surface, and as you can see, the tear film is not even mentioned here. So it is there on the surface of the eye. We know that, but there are a number of other elements that are also in this picture: the lacrimal gland, the lacrimal ducts, the eyelid, its lashes, its meibomian glands, the drainage system itself, the puncta, the lacrimal duct, and then we have the surface with its epithelium and so on and so forth. So you have the tear film as one part of a very complex ecosystem, which is the ocular surface. And when the tears go down, as in dry eye disease, obviously the ocular surface will hurt. But what I want you to now look at is the other aspect of it, that if there's something happening on the ocular surface, that can have deleterious effects on the tear film as well. So it goes two ways. It's a two-way relationship. And therefore, whenever you see somebody who comes to you with an irritated eye like this, who says my eye is very dry, very burny, very itchy, we should not immediately jump to the conclusion that this guy has a lack of tears and start treating accordingly. But I would suggest that you start looking at it in the context of ocular surface disease. And like I started off by saying, if there's one message that I want to share today with you, and if there's one thing that I want you to take home from this in 45 minutes or so that I'm going to be speaking, it is this concept of ocular surface disease versus dry eye disease. So we do have dry eye. I'm not underplaying the importance of that. Lack of tears is an important problem on the surface. But as I will show you in the next few minutes, there will be a number of other conditions on the ocular surface which can mimic or confound your diagnosis of dry eye. They can be present and aggravate a dry eye which is already there, or they can exist at independent problems. And unfortunately, all of these result in fairly similar symptomatology. Whenever the ocular surface is unhappy, it can only express itself in a very limited manner. The patient can say that he's feeling dry, itchy, burny, irritated, and this is about it. Everything else that he says are just various iterations of these four symptoms. So this is not a symptom specific diagnosis. So you cannot say this symptom leads to this diagnosis. We do have to do an examination, do some tests, and then arrive at the diagnosis. And that's what I'm going to try and share with you. So again, to reiterate that point, if you treat everybody who presented with that red irritable eye with tear substitutes alone as the generic treatment, literature shows you that you would be wrong two-thirds of the time. That many of these patients, unfortunately, have other things that are not happy on their surface. And if you don't pick that up and only try and manage it as a tear problem, we would not be right many of the time. The best way to explain this is to show you concrete examples. I've been talking abstractly so far. So now I'll try and share with you a concrete example. I'm going to show you two. This is one of them, and I'll tell you later why I chose these two patients as well. Now, this is a 66-year-old gentleman, a businessman who's very successful, a type A individual. He underwent an uneventful cataract surgery with a multifocal IOL by a colleague of mine. This was about 3 years ago. And he felt that after the surgery, he had a lot of itching, a lot of congestion, a lot of irritation, and puffiness of his eyes. And he said that it was difficulty in prolonged reading. There was a lot of early morning stickiness of this eye, and this symptom complex is not unfamiliar to most of us who see patients regularly. A lot of our patients come with this symptom complex. This gentleman attributed all of this to his surgery. He felt that he had paid a lot of money for the multifocal IOL and that he didn't get what he was supposed to get. And his doctor kept treating him with various versions of tear substitutes, different brands, different molecules. And after 3 months, he said he'd had enough. He was not getting better, and he chose to seek a second opinion. So this is not good. You get somebody who's willing to come to you for a multifocal IOL, get it done, and then wants to leave you because his ocular surface is irritated and he seeks another doctor's help. So you don't want what's happening in your business. When I saw him, his vision was 6/9 and 6 unaided in both eyes. He had very quiet eyes. He had good IOLs done. This is a very good surgeon friend of mine. So there was nothing wrong with the surgery. His IOP and fundus were normal. And as a first step, when we put in fluorescein on the surface, there was no fluorescein staining. The lower puncta were a bit stenosed, but when we used the nettleship dilator and did that and then syringed them, the passages were freely patent. So this is how the patient looks, basically. Just take a look at his eyes. We're going to look at the various findings that are there. So this is the external appearance of his eye. And if you look at him on the slit lamp, this is the appearance of the right and the left eyes. So this is what he has. And I've already told you his symptom complex. You can see the IOLs are beautiful, perfectly done surgery, but unhappy patient. So what are we going to do with this? So basically, the first thing whenever a patient presents to you with these kind of symptoms is to do a reasonably thorough evaluation of the eye and the ocular surface. If we didn't do that and if we didn't pick up the findings, we won't be able to come up with the correct diagnosis and then with the correct treatment. So let's see what's going on as this chap is concerned. So we can see that there's a lot of orbital fat prolapse in his eye. You can see the puffiness in the lower eyelid and in the upper eyelid. We can see the dermatochalasis in the left side. Basically, you can see that the eyelid is very puffy there. You can see the brotosis on the left side, and you can see the frontalis overaction on the right side. So it's all pretty obvious. We don't even have to put him on the slit lamp. Just looking at him, we can pick up all of these findings. So the weight of the skin folds of the dermatochalasis is pushing the lid down. He's trying to compensate by overacting with the frontalis and trying to open his eyes as much as he can. If we go on to the slit lamp appearance of his eyes, we can see that he has lax lids with mild eversion and there's meibomian gland disease. The lower limbus, normally we do not see so much of a show. The lid usually stays at the lower limbus. The fact that you can see so much of the inferior bulbar conjunctiva is an indicator that he has a lax eyelid. He has conjunctivochalasis. These are those little folds that you can see just abutting the lower eyelid margin. He has an increased tear meniscus, which is obvious from the light reflex that you can see there. And of course, you can see the mild congestion on the ocular surface, which is not conforming to any particular pattern. So these are the findings that we have on the ocular surface. So how do we put this together? These are the findings. So we now must use these to try and explain his various symptoms. So he feels his eye has become very puffy, and that is because of the orbital fat prolapse. He has a lot of difficulty in prolonged reading. That is because of the dermatochalasis. There's extra weight on the eyelid, pushing it down. So his levator is getting tired very easily when he tries to read for long periods of time, and he has to give up. The conjunctivochalasis is the cause of the constant irritation. Every time he blinks, basically the lids are trapping that little fold of conjunctiva between the margins. So you're pinching the conch constantly, causing irritation. The congestion is because of the lax lid, the puncta eversion, and that increased tear meniscus because of the narrowed puncta. So basically, the tears not only have they to come into the surface, they have to spread uniformly across the surface, and they have to exit the surface in an orderly manner. So it's the whole tear flow dynamics which is important, not just the quantity alone or the quality as well. So we need to have the tears come in and they have to exit correctly as well. If they don't leave the eye correctly, what happens is they pool on the surface and all the toxic stuff from the lid comes into the tear film. It continues to stay on the surface, and these noxious substances can cause irritation, and the eye responds by congestion. So whenever there's irritation, the vessels dilate and you get a red angry eye. And the stickiness is because of the meibomian gland disease and the disturbed tear dynamics. So when he sleeps, a lot of mucus gets collected. In the morning, he opens his eye, he finds it very sticky. So once you know what is happening on the surface, it becomes relatively easy to explain to the person what is going on. So we still use tear substitutes. I'm not trying to make a point that we don't have dry eye disease. We do have it. We give him tear substitutes here basically because we want to wash the surface, keep it flushed and clean while we are managing the other processes. But we do need lid hygiene measures to treat the meibomian gland disease. We have dilated the puncta and hopefully that will stay dilated and allow the tears to leave. We give him some soft steroids to control the inflammation on the ocular surface, and we explain to him some of the things that cannot be treated by these measures. The puffiness is the age-related orbital fat prolapse. We tell him that the reading is because of the dermatochalasis, and we tell him that the conjunctivochalasis is causing the irritation, and all of these are surgical problems. If he's really bothered by all of this, we have to do an orbital fat prolapse release. We have to tighten the eyelids, and conjunctival chalasis has to be surgically repaired, and then we can get rid of it. So this is a very smart man. I told you he's a very successful businessman, type A guy. So once you explain what is happening, then he's no longer worried about these things. Oh, this is aging doc. Oh, fine, I understand now. That's it. It has stopped bothering him. I don't think most of his symptoms from these have gone away. He still has those, but he's willing to accept those now. And for the last 3 years, he's been a fairly contented patient. He comes and goes with minor issues here or there. But by and large, he is no longer unhappy or angry. So while we have irritation on the ocular surface, while you may have tear problems, you can also have other things going on the ocular surface. And it is up to you to pick these up if you want to treat your patients properly. Otherwise, you may just give tears, patients not responding, and then you may have to refer it to somebody else. I'm saying you don't have to do that. You can just as well pick up these findings as well as anybody else. If you can address these yourself, then this becomes your patient, stays with you, and there's no reason to refer him to an ophthalmologist at this point. The second patient is a little bit more serious. So this first patient I presented principally because he was doing so well. He has no ocular problems, basically just irritative symptomatology. But this is a 65-year-old lady. She is single-eyed. She's already lost one eye due to glaucoma, and the other eye also is only partially seeing. So she's already in a very nervous state of mind. She comes with itching and irritation for 1 month to me. So she was on brimonidine in both her eyes from 2010. So these are patients I've seen earlier, just captured them for the purpose of this talk. So she was on treatment for close to 6 or 7 years when I saw her with brimonidine for her glaucoma. Prior to my seeing her, she had what her doctor called conjunctivitis, and this is a very broad term. Anything on the eye we call conjunctivitis. And he treated her with ketorolac and an antibiotic every 2 hours for 3 weeks. And then when she didn't get better and went back to him, he switched her from brimonidine to dorzolamide a week before I saw her. So this made her even worse. So it was 4 weeks since the start of her problem. Her vision was dropping, her comfort was dropping. She was panicking. So she came for a second opinion. Now, this is how she looks. So this is her left eye, and you can see the left eye. She's got a lot of ptosis. We'll discuss all this. The left eye basically is the blind eye. It doesn't see. She's lost it due to glaucoma. And as you can see, when you open the eye, there's a very total cataract. There's no PLI in the left eye. The right eye, when we lift the eyelid, only then you can examine it. She had that much of ptosis. A lot of light sensitivity, so very difficult to get these pictures. On the left eye, you can see that that's basically not particularly focused picture. It's very light sensitive. This is the upper palpebral conjunctiva. So just take a look at these pictures. I'll show them to you in sequence later on, and we'll have to try and find out what are the findings and how we interpret them. So this is the lower fornix and the tear film there. And this is the fluorescein staining of the ocular surface, basically the cobalt blue filter. And this is the lissamine green staining of the conjunctival surface. So I use lissamine green a lot. So this is for the conjunctiva. So these are the findings like in the first patient. So now we have to try and figure out what is it that we are seeing. So here we see there's a significant ptosis. There's a very high upper eyelid skin crease. So that gentleman had ptosis because of the dermatochalasis of folds of skin on the lid pushing him down. This lady has a very high upper lid skin crease, which means she has an aponeurotic ptosis, which here the levator is losing its hold on the lid and is slipping back into the upper fornix, and therefore she cannot lift. And you can see the borderline tear menaces as well. This is the picture on the slit lamp. You can see generalized congestion, no particular pattern, and there's some pale conjunctival edema. And if you look at the cornea itself, you can see some limbal follicles. And if you look at the slit lamp light reflex on the cornea, you see that it is shattered. In a healthy cornea, you'll see a nice, bright, round spot of light. Here you can see the scattered appearance because of the irregularity of the corneal surface. So the upper eyelid, we see palpebral follicles and congestion. And in the lower fornix and follicles, you can see the follicles congestion, but you can see a deep fornix. So there is no foreshortening. So at least ocular pemphigoid is not there here in this patient. When we do the fluorescein staining, we see diffuse superficial punctate keratitis extending 360 degrees, involves right up to the superior limbus. This is important. And as you can see, there is not much of lissamine green staining. Maybe in the left eye, there's some staining of the cornea and limbus, but not much staining of the conj at all. So these are the findings. So once you have these findings, now you have to sit and put these together to come up with a rational diagnosis. So from the tear meniscus, and her Sherma was about 8 and 9, we know that she has itching as one of her main symptoms. We are seeing follicles, therefore she has a possible allergic component. We are seeing a disconnect between the extent of fluorescein staining, which is extensive on the cornea, and lissamine, which is very minimal on the conjunctiva, and this suggests medicamentosa. If you had significant dry eye causing staining, the staining will be uniform across both the conjunctiva and the cornea because the dry eye affects both. Whereas if it's a medicamentosa, it affects the cornea more because the conjunctiva has a more robust epithelium and it's able to hold on a much longer. We have lax lids because you can see the ptosis there. We have a poor tear pump and a poor tear clearance. The lids and meibomian glands in this patient seem all right. There's no signs of OCP, and therefore the diagnosis is a brimonidine allergy, tear dysfunction, and toxicity from the NSAID, the antibiotic, and the dorzolamide, which was used for the last 4 weeks. So now that we know what is going on, we can now plan a treatment strategy for her. Because of the toxicity, the first thing is to stop all her medications, give her some unpreserved tears. We don't want any preservative toxicity. Use this plentifully 2 hourly once. There's a lot of allergy and inflammation on the surface. So give her some soft steroids. By that I mean some surface steroid, either chloromethylone or loteprednol 4 times a day. Give her some bland ointment at night to soothe the irritated surface, to build up the tear volume and help the corneal staining improve faster. The epithelium is pretty bad. We put in some temporary plugs, catgut in both the lower lids. And because she has glaucoma and we are stopping her dorzolamine and her brimonidine, we don't want that to hurt her eyes. So we give her some oral Diamox, which is okay from the surface point of view. So here again, while we do have tears as part of a treatment plan or strategy, this is a multi-pronged approach. So this is the point I was trying to make initially, that while we have tear problems, these people often have other things that are going on their surface, and it's up to us to pick these up to come up with the right treatment strategy. Otherwise, it's quite likely that we will not be able to address their symptoms and they're not going to be very happy with us. The other problems, we keep talking about symptoms so much in these patients, is that many of these patients have a symptom sign disconnect. When you have ocular surface disease due to tears, many of these said she has a lot of irritation in her left eye, and this is the left eye, and you can see the appearance there. You can see the congestion at the inferior limb. It's obviously not a comfortable eye, and this is the equivalent staining pattern of the fluorescein of the left eye. You can see the significant conjunctival staining and corneal staining in the inferior part. Now, she said she had no problems in her right eye and she was very happy with the right eye. But when you stain her right eye, you see exactly the same pattern of staining as you see in the upper picture, which is her left eye. But clinically, when you look at her right eye, you can see that the eye is nice and quiet. And so she was right. She had no complaints as far as the right eye is concerned. So, as far as the symptoms are concerned, she is symptomatic in the left eye, absolutely happy with her right eye. But when you look at the signs on the right pictures, they are similar in both the eyes. So this is the point we're making about this disconnect between symptoms and signs that often we see in these patients. So it's up to us to make sense of these things. So how do we do that? The Deuce said that we should do some tests, the Deuce 2. So this is the famous cartoon that they came up with. So they said basically we do some symptom analysis and screening, and if this suggests that this patient has a dry eye related disease, then we go through some tests. The first set of 3 tests that they suggested is here in the blue column in the middle. So this is the test that look for the loss of homeostasis. The tests are: one, the non-invasive tear breakup time; second is osmolarity; and third is ocular surface staining. Now, unfortunately, of these 3 tests, most general clinics will only have ocular surface staining. Most clinics will not have a special tool to do NIBUT or non-invasive BUT and to measure osmolarity. And if any of these are wrong, if the homeostasis is altered, we then believe the patient has a dry eye, and then we go on to try and look at which part of the dry eye spectrum the patient exists in. Is it the evaporative dry eye or the aqueous deficiency dry eye? And in order to do this, you look at the picture on the right side. There are 3 tests that have been suggested: mammography, which is to image the meibomian glands using infrared devices; lipid interferometry, which is to analyze and measure the tear lipid on the tear film; and tear volume measurement, for which they suggested that we do a tear meniscus height measurement. Unfortunately, all of these 3 require special investigations, which again are not available to most people in a general clinic. So the worry here at this point is, if the DUCE 2, which is the most recent recommendation, talks about 6 tests, of which 5 are no longer available to us, how are we going to diagnose dry eye? I'm going to show you that you can do a very good job with whatever tools you have in your general clinic without having to invest a few lakhs in any of these fancy equipment, and we will see how that happens. So symptoms basically are important. The OSDI score, the Ocular Surface Disease Index, freely available on the net. You can download it and print it out for yourself. Keep it with you. When the patient comes, you ask him to fill it out himself. So basically, based on the score that you get, you can decide how bad is the symptom score. So the more red the score is, the worse the symptom is. So very easy to do. So this gives you an idea of how much this is troubling the patient. And more importantly, it gives you a documentation so that when he comes back 2 months, 3 months after your treatment, as the score keeps coming down, both he and you can appreciate that your treatment is working and that he is feeling better. So OSDI, free tool available on the net. All of us can do it. Doesn't require any equipment or expertise. The next thing we talked about in our definition is tear film instability. So we traditionally do the fluorescein breakup time. The reason why the Deuce 2 thought this was not very physiological is because breakup time looks at the time it takes for a dry spot to appear on the corneal surface, and we use that as a surrogate measure of the mucus and the stability of the tear film on the surface. But if you're adding fluorescein with a teardrop into the eye to measure it, it is unphysiological. So in an effect, they are correct. If you want to measure this in its true state, we have to do what is called an NIBUT. So we don't add any tears of fluorescein to the surface. We project a grid onto the surface, and like this, a device which will project a grid. And if you can see, there is some shattering near the temporal pupil here. And on the other picture, you can see those breakup zones showing up there in red and all that. So the machine actually tells you where the tear film broke up first and how long it took for the tear film to break up without the addition of fluorescein or additional tears. So it is more physiological. But the Deuce 2 itself acknowledges that if you do not have a device like this, if you do your fluorescein breakup time in a consistent and repeatable manner, you can derive better values from that. You must remember that the NIBUT values are generally a lot lower than the TERBUT values. So basically, if you, depending on which of these tools you're using, you have to interpret your BUT. Hyperosmolarity, again, there are devices, there's something called the tear lab, a pen-like device. You put a little strip of filter paper or onto the tear meniscus, suck a little, and then shove it into this pen, and it gives you a value. So if the osmolarity is more than 308 milliosmoles per liter, we think it is hyperosmolar. Basically, though, you don't need it. Most institutes also don't have it. And even those institutes which have it use it only for research purposes and for testing. Nobody I know uses it for routine clinical use. So tear film instability, we can get away with the fluorescein BUT. That is all we need to do. We don't need thermography. We don't need osmolarity. We don't need measuring the tear evaporation rate. These are research tools, so we don't have to worry about it. So if you have the NIBUT, very good. It gives you slightly more physiological data. But if you cannot get it, do the FBUT and you'll still be very good at assessing tear film instability. How about tear volume? So basically, we do the standard Schirmer's test, which all of us know. We use the filter paper, we put it in and do it. Meniscometry is a little bit more accurate because you're measuring the tear meniscus of the lower tear lake, and therefore you're looking at what is there rather than getting a surrogate measure from the Schirmer. And this is how the device will do it. It gives you a highly magnified image of the lower lid and the tear meniscus there. It draws lines along the upper and lower border, and then you can put these markers and measure the tear meniscus at different points, and it gives you a value. So some of the work you have to do. The machine is not going to do everything, but it tries to give you a quantitative number of the exact height of the tear meniscus. But here again, if you don't have a tear meniscometer, it doesn't matter. As long as you do your Schirmer test repeatably in the same manner again and again and again. So if you're using anesthetic or not using anesthetic, if you're doing it with the eye closed or with the eye blinking, if you're doing it with the AC in your room on or off, and generally I prefer if you turn your fan off when you're doing it. And if you wait for 5 minutes and use standardized strips, which are easily available today at not much cost, I think they cost ₹1 a strip or something. So you can do a good assessment of the tear volume using your Schirmer test. So a tear meniscus, like the NIBUT, is good to have, but it's not a must to have. You can do the same thing with a Schirmer as well. Ocular surface damage. So here we have lissamine green on the left, rose bengal in the middle, and fluorescein on the right. So these are the three things that we use to measure. Generally, fluorescein is used to measure corneal surface epithelial damage, while we use rose bengal and lissamine to look at the conjunctival surface epithelial damage. These strips also easily available, about ₹1 per strip or something like that. You can all do it. So very easy to look at it. So what are we looking at actually? So when you're using rose bengal or lissamine green, we're looking at the staining across the entire ocular surface. The way I do it, I look at the temporal conjunctiva, I look at the cornea and the nasal conjunctiva. So each of these areas we score from 0 to 3. 0 means there is no staining, 3 means that the entire area is stained, and 1 and 2 is semi-quantitatively 1/3 and 2/3 of the area. So the total score will be 0 to 9. So each area is 3. So you get a value between 0 to 9. And it's also important not just to note down the value of 6 or 7, but to know which area stain more than the other. So this will give you some diagnostic clues. And also when the patient comes back for follow-up a month later, you'll know if he's better or not. As far as fluorescein staining on the cornea is concerned, we draw two horizontal lines, upper one third and lower one third and middle one third, and again score each of these three areas from 0 to 3 to get a total score of 9. The line of marks is seen on the lower eyelid margin just behind the meibomian gland orifices. Those are those fine red dots you can see there. And that is the normal position of a normal line of marks, just behind the openings of the meibomian glands on the lower lid. So this is basically the extent of the tear meniscus on the lower lid margin. And as the patient develops a tear deficiency and the tear volume reduces and the tear meniscus gradually recedes backward, the line of marks will gradually move posteriorly towards the posterior lid margin. So this is the significance of the line of marks. So these are the two lines that we draw for the conjunctival staining. These are the two lines for the corneal staining. We can also do impression cytology to look for ocular surface damage, but it requires a path lab, requires a pathologist, and the ocular surface sensitivity is lost when you have ocular surface damage. So you can use either an adjet esthesiometer or a Cauchy-Bonnet, which is easy to get, basically a length of wire which you use, and then the amount of wire tells you how much sensitivity is. But again, like I told you before, yeah, for ocular surface damage, ocular surface staining is really the sine qua non. So basically, if the tears on the surface is not adequate for that particular eye, the surface will stain. It's as simple as that. So all the other measures are good, but they are not necessary in a general clinic. They are research tools. So all we need to do for ocular surface damage is ocular surface staining with fluorescein and either lissamine green or rose bengal. Ocular surface inflammation, basically, this is a common clinical sign. Like I told you, in both the patients, we saw congestion. So any unhappy ocular surface with inflammation will show redness because of vascular dilatation. And this is how the eyes look. So you can get tools which can take pictures, and you can use the pixels where the eye is red to be scored as a given value, or you can look at a universal scale and just compare it. But basically, for clinical purposes, if we can just have it as mild, moderate, or severe, and in your head, if you have some standardized way of doing it, you will be good already. So a healthy eye, a happy eye is often white and quiet. An inflamed eye is often very red. So that is all we need to remember. So just like the tear lab, which measures hyperosmolarity, we have a device called the inflammadry, which measures the MMP9 levels on the surface. And this is one marker for inflammation. So if it is elevated at 40 nanograms per mil, then we believe there is inflammation. But again, more of a research tool. So don't worry about it. So ocular surface inflammation is important to assess. Redness is your guide. So have some classification. You can download one of these universal scales from the net and keep it in you. We print it out and keep it with you and compare it, and it goes from 0 to 4 or 0 to 5. And you can say this is 1, 2, 3, or 4. But I just do it in my head. So I talk about it as no inflammation or no redness, very severe redness, and mild and moderate redness. So there are 4 categories, and I just put it down as 0, 1, 2, or 3 in my file when I look at these patients. Now, as far as the meibomian glands are concerned, so this is all you need. You need to flip the eyelid and look very carefully and closely on a reasonably good slit lamp. And you can see these pale yellow ridges that you can see vertically aligned. There's about 20 to 25 of them in the upper and lower eyelid. And you can look at the morphology. But if you have an infrared tool, you can basically get these nice images of the meibomian glands because of the oil in them on the infrared. It lights up and you can see their morphology better. And the reason why it's important, like this particular girl who had significant dryness, went through various operations, was not able to be treated, and then was referred. She has a congenital absence of meibomian glands in her lower lid. You can see only one deformed meibomian gland in the lid. All the rest are missing congenitally. And therefore, she had an evaporative dry eye, which we needed to manage. These machines also allow you to actually estimate the amount of meibomian gland area that is present, and the dropout and loss can be calculated. Not essential. And even if you want to look at it, most of us have an autorefractometer. These are again using infrared. So just flip the eyelid of the patient, sit them at the autorefractor, and when you look at it, you can see exactly the same pictures without having to buy a dedicated device. So if you're very keen on doing meibography, you can use your autorefractometer. But if you just spend a little time and patience and train yourself to look at the eyelid itself, you can easily identify these yellow worms in each of the lids, and then that will give you a good assessment of what is going on. The next thing is the tear film lipid layer. So this is tear film interferometry. So this shiny image that you're seeing in the center is the lipid layer. We can measure the thickness, or we can look at it and say whether this is a very thin film, a moderate film, or excessive film. And this allows us to judge. But this requires a tool. It requires a costly device. What we can do, however, is to do a standard expression of the lid. So put your thumb on the lower eyelid, trap it between the globe and your finger in the middle of the lid and give gentle pressure, not enough to hurt the patient, but there must be gentle, firm pressure. This usually will be pushing on the openings of the middle 3 or 4 meibomian glands. Then you look at how quickly the oil comes, you look at how much of the oil comes, and you look at the quality of the oil. So this tells you whether if it comes easily, then there is no problem. If it's not coming, even pushing, then there is no oil. Or when you just push, if there's a gush of oil, that is not good. So that's the quantity of the oil. Then you look at the quality of the oil. Normally, it's just a thin, a small bead of clear fluid. If you get a copious outpouring of fluid, that is meibomian seborrhea. If you push, nothing comes, there's a silent meibomian problem. Or if you push and you get something like a toothpaste, like Colgate toothpaste, a white tube coming out, that is meibomitis or meibomian inflammation. And the number of glands which express will also give you some idea of how functional they are. When you push, if all 4 are expressing, very good. If only 1 out of the 4 is expressing, then that's not good. It means the glands are not functioning. So if you can get a lipid interferometry, wonderful. But if not, don't worry. The same information comes from just pushing on the eyelid with your thumb. And by looking at the number of glands which express, the amount of expression that is happening, and the quality of the expressed oil, you can get useful clinical information. And the last thing is the lid blink closure. So sometimes people don't blink completely. The machines can give you an automated video analysis of this, but all you have to do is to basically look carefully at the lid and you'll know whether the patient is completely blinking or not. Just sit him at the slit lamp, ask him to gently close his eye, and then see if there's any area of the ocular surface visible with the closed position, or if the upper lid completely contacts the lower eyelid. So, ideal tests basically should be available in clinics. They should be easy to do. They should be both sensitive and they should be specific, and they must be most importantly cost effective. So, this is what all of us are looking for. So, based on what I told you, this would be your basic profile. You do the OSDI, you look for the ocular surface redness, you do a fluorescein BUT, you stain the surface with fluorescein and lissamine, do a Shermer, and do a meibomian gland assessment, and this will complete your profile. If you're in an institute and if you have access to fancy devices, then to add on to this, you can do an NIBUT, an osmolarity, a tear meniscus height measurement, an MMP9, and look at meibography and the lipid layer. But what I showed you before is exactly the same as this in a clinical manner. So you will get information without quantifying it, but you can get useful information from these tests. So the evaluation itself is becoming increasingly complex. So like I told you, NIBUT for the mucus, tear meniscus height for the aqueous, and lipid interferometry for the lipid component of the tear film. We're talking about costly devices for each of these. If you have a tool, you can get examination reports like this. So I look at meibography, the machine tells me the score. You see that little black pointer there. If it's in the green, it means that the meibomian gland area is normal. If it's in the red, it means a significant dropout. And if it's in the yellow, it means it is suspicious. You can do the same thing for redness and other things. This is the device that I have. It's called the IDRA. It does all of this interferometry, tear meniscus, whatever, blah, blah, blah. And it gives you one nice composite report. So it's useful. So I can give this to the patient. I can show it to him. I can use it to explain various things. And he's very impressed that all this has been done. But it's quite expensive to buy, and it's quite expensive for the patient. Each time I do it, there's a charge for the patient. So if you can have it, it's nice. But I was doing all of this even before I had this tool, and I don't think it's absolutely essential. If you took it away from me, I would still be able to do my ocular surface work equally well. So that is why I wanted to share with you the importance of the clinical exam, the clinical tools that we have. But if you're in an institute and if you have any of these fancy devices, there's nothing wrong in using them as well to aid the diagnosis. Now, this is about getting the findings and the test reports. So you have to put them together, isn't it? So the BUT basically tells you about the mucus, the Shermer tells you about the aqueous, and the lipid film tells you about the lipid layer. Obviously, it's in the top row. If everything is normal, it's a normal eye. In the bottom row, if all of these are decreased, it's a very severe dry eye, both aqueous deficiency and evaporated. And in between, you can have various combinations. You can have a preclinical aqueous deficiency or a preclinical evaporative dry eye. By preclinical, I mean that the Shermer is lower than what you think is normal. But when you look at the BUT is normal. So even though the tear volume is slightly reduced, it is not yet breaking up the BUT. and therefore it's a preclinical dry eye, either aqueous if it is the Schirmer or evaporative if it's the lipid. When you have a clinical aqueous deficiency dry eye, the Schirmer will be low and the BUT will also be low. That means there's not enough tears to keep the surface covered between blinks, and so also for the lipid. Now, what is the most interesting thing here is the last but one column. If you look at the column one from the bottom, you have the BUT is decreased, but the Schirmer and the lipid values are normal. So you are having normal lipid and normal Schirmer, but a reduced BUT. So this is what the Japanese call a short BUT dry eye. They think this is something to do with the mucus layer. So the cornea is not able to absorb the tears long enough to keep it moistened between blinks, even though the tear volume is normal and the lipid is normal. So there's something wrong with the mucus on the ocular surface. So they treat these with mucus analogs. They give them diclofenac, which we don't have in India as yet. We have ribamipide, so we are trying to use ribamipide for the same thing. Both ribamipide and diclofenac are able to cause mucus secretion from the conjunctival goblet cells, and therefore we try and treat this. So this is a very specific entity where the BUT is abnormal, but the Schirmer and lipid are normal, and the Japanese are the ones who, we've been talking a lot about this, and they say that their patients are extremely symptomatic, and it's very easy to miss these patients because the Schirmer is normal. There's not much staining on the corneal surface. You tell them, oh, you're just imagining it. But they have found out that these people are very short BUTs responsible for this. So after you've done these three, you have to also look in the bottom for inflammation, and you have to look for damage from ocular surface staining. And what I've been talking about again and again about these other conditions which mimic, confound, or aggravate. So you have to look for all these as well. So this slide, in essence, is the composite of everything that I've spoken about in the last 35 to 40 minutes, basically about how you make a diagnosis and what goes into making a diagnosis of ocular surface disease. So what are these other conditions? Why is it so scary? So this is the slide. This looks like a very scary slide, basically. But I just wanted to put it here to tell you that if all of these are common conditions, there's nothing unique about any of these. As long as you have these in your head and you're aware that all of these can impact the ocular surface, then you will be able to basically make a correct diagnosis. I'm not going to go into it in detail because that actually forms an entirely separate talk, another 45 minutes or so I need. But I will just very quickly go through these various conditions. I'm going to start at the top left and I'm going to go one at a time. My pointer on the screen is not working for some reason. So start with me on the top left. So this is basically adenoviral conjunctivitis. So before, during, and after conjunctivitis, there are a number of ocular surface changes. The next one where you see the pale conjunctival edema is allergy. Then you see that lady sitting with her hands on a nose, bridge of a nose. So this is basically asthenopia from accommodation of convergence issues. Then you can have canaliculitis. We will have findings mostly in the medial canthus. Then you have thyroid eye disease. Then you have contact lens induced changes. And again, if you come back to the second row starting on the left, lagophthalmos, filamentary keratitis, concretions, aqueous deficiency with staining on the surface, environmental conditions of humidity, air conditioning, and so on, preservatives from the various teardrops that many of our patients use. Third row, floppy eyelid syndrome, HIV, which causes dryness and tumors like kaposi, lid laxity causing punctal eversion, lid hyperepitheliopathy, where you fold the upper eyelid and you find the mucus pad there staining, conjunctivochalasis, and parasites on the lid margin. Fourth row bottom, basically meibomian gland dysfunction. Then you have staphylococcal and seborrheic blepharitis, limbal stem cell deficiency. Here you have basically medicamentosa, and then you have basically a lot of inflammation of the eye due to thyroid eye disease as well. On the fourth row in the bottom, you have mucus fishing syndrome, neurotrophic keratopathy, carotid cavernous fistulae, basement membrane disease, Muhammad Ali with Parkinsonism, where he doesn't blink at all, and that causes surface changes, and then lid margin keratinization due to basically the lid margin on the Stevens-Johnson syndrome. Last row, acne rosacea, superior limbic keratoconjunctivitis, plictenular keratoconjunctivitis, limbal contour changes, corneal changes like edema, systemic medications and their side effects. And the last one on the bottom right, tear stasis, increased tear volume. So increase in tears on the surface and a lack of drainage will produce pretty much the same symptoms as a lack of tears in the early stages. So these are the various conditions. As you saw, nothing very exotic, nothing very difficult. All of us deal with these day in and day out. But the trick is to keep these in mind when you're dealing with these people with ocular surface symptomatology and try and factor them into your diagnosis. So there is no single gold standard dry eye sign or symptom. However, clinical evaluation is possible, is very efficient. You just have to be aware of the sensitivity and the specificity of the tests. You have to be aware of the symptom sign disconnect and the fact that many of these tests, there's a significant overlap in values between normal and patients, and that segregation is better when you do more metrics. I showed you 7 on that slide, which I thought was ideal. So the more of these tests you do, the more information you get and the more rounded your diagnosis becomes. So I'm down to my last few minutes. Basically, referral guidelines. I think this is what I would do if I was an optometrist and I had an ophthalmology colleague working with me. When I had a doubt about the diagnosis, then obviously before I do anything and interfere with the patient's surface, if I don't know what is happening, I've done my best, I'm not able to figure it out, then I want a second opinion. If I think I know what's happening and I've given him my basic medications, what I normally give in this condition, but when the response to that is not what I am used to seeing, when the response is inadequate, then I would refer. There are very troublesome patients who, after 1 or 2 visits, are starting to create trouble or they want a second opinion. Then it's better for various reasons to get a second opinion to keep the patient happy and to make sure that he knows that we have not missed anything on our side. When there are changes on the cornea or the ocular surface, if you have a lot of corneal damage happening, if you have a persistent epithelial defect which is going on for a while, and you're not able to heal it with whatever measures you have at hand, then I would refer, because this is tectonic, it's interfering with the vision and the stability of the eye, then I would not keep them with me if I cannot heal them. And there are patients in whom you may expect surgical management to become necessary. And because optometrists at the moment are not allowed anything surgical, if you anticipate that surgery may come, it's better to involve an ophthalmologist right in the beginning so that between the two of you, you can take care of the patient and he can do the surgery and you can follow them up. And last slide, co-management. I think if you want to do that, I think it's very important that you establish a healthy relationship with the ophthalmologist. There are 2 kinds of referrals, obviously. One is when you don't want to manage that patient anymore, when you think it's very complicated, you just want to send it to somebody to take him off your hands. That's one way to do this. But that's not necessarily the correct way. There are other patients where we want an opinion, where we think the ophthalmologist can have his input, but then the patient, we would like them to come back to us so we can take care of the basic other stuff for the patient. So that is where it's really a co-management. So that the role of each of these, yours, mine, the ophthalmologist, the optometrist, must be clearly defined. And that comes from having a healthy relationship with the ophthalmologist. So if both of you are very clear as to what the patient is being sent for, what is it that they should do, and what is it that you will be doing, then there is no confusion. So usually what happens is I have patients who are referred to me for very complicated issues. They come to me. I try and make my diagnosis of what is happening on the patient. I try and set up the treatment protocols. I basically will give then a letter to the referring optometrist, talk to them, SMS or something. Some way I communicate with them, let them know what I think is happening. Usually, if it's very complicated, I may keep the patient for about a month or so till I bring everything back to the baseline and make things stable. And then they go back to the optometrist. So then the follow-up that the optometrist does is much easier for the patient as well, because now it's very hard to travel in Chennai. If the optometrist is close to the patient can see them regularly every month, every 3 months, depending on the disease. And then the follow-up is done. So we've already know the metrics, we've already spoken about it. So they just ensure that the surface is stable, the patient is asymptomatic, comfortable, and as long as things are going on, they carry on managing the patient. Maybe once a year, they send them back to me for me to monitor the underlying disease to make sure nothing is being missed. On the other hand, if basically this can also be done by teleophthalmology these days, they capture a picture on their phone and send it to me, which most of them do, and so on. So there's no need to basically send the patient back each time for me to see. Once a year or so, they come basically because if there's an OCP, then I want to make sure that the patient's stable OCP wise. But if you're managing the patient for follow-up 3 months, 6 months, and if you find the condition worsening, and despite the teleconsultations that are going on, if things I'm suggesting something or the ophthalmologist telling you, let's try this or that, he's not getting better, then that is when you need to send them back. Or while you're following up, you start the surface, you see that starting to break down and you think, oh, something needs to be done. Then, so the trick and challenge in co-management is for you to be able to recognize when it is appropriate to send the patient across. And these are the basic guidelines that I can think of. So if we can stay with this, basically, I think the patient will benefit. The patient doesn't leave the optometric practice. They go back to them for everything else. But as far as that one particular aspect of that disease is concerned, where some more specialist help is required, probably the ophthalmologist can step in and help you out. So this is basically what I could think of when we talked about referral and co-management guidelines. Maybe there's anything else that you have that you want to specifically address. I think we have another 15 or 20 minutes of discussion time. I'd be more than happy to answer those. Thank you very much.
Thank you, sir. So we do have around a dozen questions for you.
Sure.
We will start off with Dr. Krishna Kumar's question. Can you share
Yes.
information on occupational related dry eye? What simple tests can be done at outreach setups? Any specific visual hygiene guidelines or preventive care?
It's the occupation related dry eye. Basically, there are two aspects to this. One is somebody who sits indoor all the time, and one is somebody who's outdoor all the time. So both of these are detrimental. So give you an example. Obviously, today most of these people are software professionals, and after this COVID, I think most of them are working from home. So they just sit and keep working. So here, I think there are two or three aspects that we have to remember. Most of these are young, healthy adults. So they're all in their early 30s, late 20s, something like that. So there's usually nothing wrong with their tear film, unlike an 85-year-old post-menopausal woman who has an aqueous deficiency. But here, what happens is because they sit and stare at their visual monitors for long hours without blinking or with low blink rates, they develop an evaporative dry eye kind of state. So here, there is not so much of medical management that we need to do. It's more of counseling that you have to do. The three most important things are: one is to blink frequently and voluntarily when you stare at a screen. Two is to break your work into smaller aliquots and not do 10 hours at a stretch, which many of them tell me that they do. They do 2 hours, they give a little break and do. Also, because you shouldn't forget that accommodation and convergence are being stressed considerably in these individuals. So if you're going to stare at this 45 or 50 or 60 centimeter distance for 10 hours at a time without giving your ciliary muscle any rest, it's going to hurt you after some time. So we have that 20-20-20 rule. Nobody can do that. You can't stop every 2 hours. No, but then at least I tell them, give a little break, whatever is convenient for you. You know, it's very hard to set a stopwatch and every so many minutes go and look at something for so many minutes and come back. They won't do that. So that is the second thing. And the third thing, the most important thing is because of the weather in Chennai, most of us are hot. So we always have an AC running like I do now. And you have a fan also as well most of the time. And you do not want the cushion of air from all of these to be on you. So you have to basically not really educate them, but inform them of these aggravating factors and tell them that on top of this, if they still need some support, send some tear substitutes which you're well eligible to prescribe can be given. Something, if they're going to use it on a long-term basis, something with a disappearing preservative like purate or perborate would probably be good because you're going to use it 4 to 6 times a day for a period of time. You don't want any preservative toxicity. So this is from the indoor part of it. Look at the asthenopic part of it and the dryness part of it. The outdoor guys are these people who are basically these representatives and all that. So they travel a lot. They get onto a bike, they go from one place to the other, they sit in front in a doctor's clinic for 2 hours, meet the doctor, then they get on, they go again. They travel many times during a week. They go from one city to the other. So they are being exposed to all kinds of adverse environmental conditions. So again, when they drive a bike, many of them, nobody wears a helmet. These now it's getting enforced, but they don't have a visor on the helmet. Sometimes they don't wear a protective glass. So they're exposed to the breeze and the wind and the micro environment and the micro trauma from the dust and the diesel and all that. So these people have partly an evaporative state and partly an allergic state because the diesel particles in the environment function as haptens. Basically, they are able to set up allergies to other things. They maximize the allergies. So when these constantly keep hitting the patient's eye, after some time they get an irritated eye, partly from the evaporation, partly from the allergy. So here the most important thing is for them to wear some kind of protective eyewear, some goggle-like thing when they drive around a lot. And again, some tears when they finish a long drive. When they get off, if they can't go and find clean water to wash their face in this ocular surface, put a couple of drops in so that it flushes the surface before they go meet the doctor and start the next round. So something like this is what I would say. There's really, the tests remain the same, really. There's no specific test to diagnose these. The only thing is the tests will be important in these people because they will all be negative. If you do a Schirmer, it will be normal. Oftentimes, they may not have much staining on the surface. The meibomian glands may be a bit off because they sit and work long hours on the system. So the findings on the tests are more important from their negative aspect rather than they have a lot of symptoms, but you're not able to pick up equivalent findings on the signs. That's because it's an evaporative state.
So what about the tests which you would advise for outreach setups?
I think it's the same, ma'am. The OSDI anybody can do. It's just a patient hearing of the patient's symptoms. The OSDI is a formal documentation of that. Then you can do a Shermer. I think whether it's an outreach clinic or you can still do a Shermer. If you don't want to do a Shermer, you don't have 5 minutes. You're seeing a large volume of patients. Then the ocular surface stain becomes the most important thing, because it gives you very quickly the BUT and it tells you the staining pattern. So the staining is important because, like pressure in glaucoma, we have guidelines. We say 21 for IOP is a cutoff. So people with higher IOPs tend to have a statistically higher risk of developing a pressure-induced damage to the nerve. But we also know that there are people who can hurt their nerves at 16 pressures. There are people with 24 pressures who have healthy nerves. So the ocular surface staining is the most important thing, because you may have a myopic eye, a very large protuberant eye with a very wide palpebral fissure. So there, even a normal tear film may not be adequate to surface that large tear film area. On the other hand, if you have fairly small palpebral fissure, tight lids, and very narrow exposure, even a small volume of tears may be enough to keep you adequately covered and protected. But if you see staining, and then it means that the surface is hurting. So then you need to step in and do something. So if you have only the one test that you can do, if that's what you're asking, what will I do for the patient who comes in? I would say a fluorescein staining of the ocular surface, because it tells you whether there's damage. It gives you some idea of the BUT, able to give you a clue. If you want a more complete diagnosis, then obviously you must do the rest of it as well. You have to look at the lids, you have to look at the symptoms itself, you have to look at the other things that I talked about, the Shermer value and so on. If you don't have time to do all the 7 that I showed you, then do a fluorescein alone. That might be a quick and easy guide for you.
Right, sir. And since you've mentioned OSDI, there are 2 questions related to the questionnaires. Instead of, this is one question from Mr. Manish. Instead of OSDI, can we use speed questionnaires, which is the gold standard? Yes. And Ms. Preeta asks, there are so many questionnaires, OSDI, DEQ, McMoney's. What do you use? Which questionnaire is best?
I personally use the OSDI, not because it's the best, because this is something that Allergan brought in early on, I think, I can't remember now, more than a decade ago. They came up with even a software-based version that you could put on in those days, we used to use those DVDs or CDs, nobody uses them anymore. So we used to put it in, and if you could go through it as a software-based tool, but it's freely available on the net. It's easy to download, and therefore you can just as well use the speed. You can use the McMoney's, DEQ. It doesn't really matter. But for Indian conditions, I think personally the OSDI is fairly simple. It's only about 13 questions, so it's not very difficult to do. The questions are something that the patients can relate to quite easily. And therefore, I use it, not because it's the only one or not because it's the best. You can use the speed as well. So it doesn't matter, as long as you get used to it, you get comfortable with administering it, and you get used to interpreting it. And that usually happens when you stay with one. You can't do one day this, second day that, third. That doesn't make any sense at all. So that is why I prefer the OSDI, but you're equally welcome to use any of the other ones as well. They're all as good.
The next one is on Shermers. It's a 2-part question. Yes. How reliable is it to do Shermers for 1 minute and Shermers for 5 minutes? This is with Shobha's question. And any difference between doing Shermers having eyes open and closed? Is it going to affect the tear secretion?
The 1 minute Shermer is not a good idea. If you want to do a 1 minute or a 20-second or a 30-second test, you have to make sure you get access to the phenol red thread. And if you have that, that is intended for doing for 20 to 30 seconds. The Shermer 1 minute is probably not a good idea. I think the variability will be way too much. Whether you do it open or closed, you will have a difference in the results, but it doesn't matter. The only thing is, if you're doing it open, you do it open. If you're doing it closed, you do it closed. So that way you will get some consistency. That's what when I mentioned the Shermer, I told you it's very important for you to decide when in your testing you're doing it. Make sure you use the standard Shermer strips, and that's very easy today. They're commercially available. And then you can either ask the patient to keep blinking. Nobody keeps it open for 5 minutes, obviously. They keep blinking. That's what you mean by an open eye state. You allow them to blink. Or you can ask them to keep their eye closed, and then for 5 minutes later, you can take it off. And the last thing is about the fan and AC in your room. I normally leave the AC in my room on because in my clinic, my room, the AC is not directly in the path of the patient's chair. So it's okay to have it on, but I turn off the fan. The fan's always on. But before I start my Shermer, I turn it off. So when I do the Shermer with these standard conditions again and again and again, I get repeatability in my hand. So I do it with the eye closed. I ask the patient to keep the eye closed for 5 minutes, and then I interpret it after that. In those 5 minutes, it gives me time to write my notes, to make my findings. And all. I keep asking patients questions. I tell them, you can answer my questions, just don't open your eyes. You keep your eye closed and keep answering. So that 5 minutes while I'm waiting for the test, I fill in my file. I ask a few questions about his rheumatoid status and this and that and all that, whether it's worse in the morning, worse in the evening, dry mouth, whatever I want to ask. So we spend that 5 minutes usefully. It's not like the patient sitting there for 5 minutes and nobody's talking for, As it is, this whole workup takes about 15 to 18 minutes to do if you do everything that I mentioned. So it's a fairly elaborate workup for a patient's ocular surface.
So Shobha also asks, how often would mebography be done for a follow-up patient?
Basically, I don't do it for follow-up patients. I do it in the beginning to document it, and more important, because we now use some light-based treatments for people with significant meibomian-related ocular surface dysfunction. I want to make sure that there is enough glands in the lid for me to stimulate with the light-based therapy. We use the intense regulated pulse light, or the IRPL, to try and stimulate the nerves, the deep nerves, which we believe alter the function of the meibomian glands. So you can only do this if you have at least about 40%, I would say conservatively, of the glands intact. If you had significant gland dropout, and if you have less than 40% of the glands functioning, then there's no point in subjecting the patient to treatment like this, because there are just not enough glands for you to stimulate. And also, if you're going to put the patient through a lot of lid massage and this and that, you want to make sure that the patient has the distended type of meibomian gland dysfunction, where there's excessive oil that you can squeeze out. If you have glands but they're all atrophic and thinned out wires, thread-like glands, then the stimulation is not going to help you. So we do it in the beginning to assess the status of the glands, to try and decide which type of treatment will be of help to them, and then we do it. After that, the assessment is based mostly on the symptom improvement and the sign improvement. So I don't have to keep repeating meibography at periodic times, unless you're in a study situation.
So you've actually partly answered Ms. Preeta's question also, which was on what's the treatment for MGD, and is the neuromodulation therapy useful, or massaging would help? Any point you would want to add for her? So we could go to...
They are basically not, they are not the same. I think we have devices like the Lippy Flow, which is the mechanical equivalent of your massage. And then you have the light stimulation. So the rationale for each of these is different. So like I said, meibomian gland disease will be of three kinds. One is the silent kind, where when you push very hard on the lids, there is no oil escaping from these gland openings. So there they have an evaporative state because there is no oil covering the surface. The second kind is the meibomian seborrhea, where you push and you get excessive oil flowing into the eye. So this again causes a BUT type of dry eye, because the oil contaminates the corneal surface, prevents the mucus from staying long enough, because it makes the surface of the corneal surface hydrophobic. And the third kind is the inflammatory kind, where you push, you see a lot of white paste-like material coming. So that is the third variety. So once we decide which is the problem, I usually start the patient off on a type of massage kind of regimen. So they do a hot fomentation, they do a lid margin scrub, they do a massage, and then they rub in some antibiotic ointment onto the lid margin. Depending on the surface changes that I find, I may add a soft steroid for the first 2 weeks, because when you massage and bring all the inflammatory stuff into the surface, the inflammation can go up. You may also want to add some oral macrolides like doxycycline, and sometimes we give them some omega-3 fatty acids if it's really very bad. So this is the first step. If after 3 to 4 weeks, if the patient tells me that he did the exercise properly and regularly and still does not see the desired benefit, then we talk about putting him on the IRPL. The Lippy Flow is to avoid the 3 weeks of massage. If the patient says, oh boss, I'm a very busy guy, I can't sit around doing 10-15 minutes of all this nonsense in the night, then we ask him to pay a lot of money, and then he goes and sits at a LipiFlow machine, which takes about 40 minutes or so, and then it does the whole thing, the heating, the squeezing and all it for him, and then he goes away. So if he has plenty of money to spare and doesn't have time, then he does that. But if he's done all this properly and he's managed to bring the oil quantum under control by the massage, but he is still troubled, and I think it's the quality of the oil which is an issue, then we put him through the IRPL. So the IRPL, the deep neurostimulation, tries to modify the quality of the oil. So the two have to be done together. You have to squeeze out the excess oil with the massage or the LipiFlow, and then if you still think it's necessary, you do some modulation of the quality of the oil with the IRPL. And the third element, after all this, if you still think he's not doing very well and you see a little collarettes, then we think in terms of a Demodex infestation along these glands, and then we put him on some tea tree oil scrubs as well. So it's one stage at a time, depending on my assessment of how bad it is, patient symptoms, and the surface changes.
So the next question is on scleral lenses by Ms. Devakani. What's your call on scleral lenses in moderate to dry eye, that is filling scleral lenses with non-preserved saline in commonly practiced scenarios, and what's your advice on the treatment?
It's definitely not for mild to moderate because, as you know, pros lenses are quite expensive. Not many people can afford them, and they are not very convenient devices as well. So for mild to moderate, the cost, the hassle of using them, and the difficulty in putting them on and taking them off will more than outweigh the benefits. So these mild to moderate can very easily be managed by the other medical measures. The pros lenses actually come into their own when you have a constant surface of ocular surface damage which is happening or which is operating all the time. Typically, when you have some lid dysfunction, lid margin keratinization, or some such scarring related issue, trichiasis, and so on, where every time the patient blinks, there's a friction related trauma that is going on, which is really what the pros lens is good at dealing with. So it keeps the lid off the ocular surface and the cornea and keeps it healthy. The added benefit of having a moist environment from the tear lake that you create by putting a lens on the eye is an added benefit. But I would think it would be excessive to use the pros lens just to give the tear cover to the corneal surface in a mild to moderate situation. I personally don't think it helps.
How about humidifiers in rooms, especially at workplace, will it reduce dry eye?
Chennai, our normal humidity is 85 to 90%, and most times the clothes also don't dry. So I think that's not a major concern. But if you're sitting in a in a Western country where it's very dry kind of weather, then a humidifier will work. But in the Indian context, I don't think so. The air conditioning that we use doesn't lower the humidity all that much, honestly speaking, unless you're really in a very powerful air conditioning environment. So I think it just makes sense to make sure that you don't sit in the throw of the air conditioner. I think that is the more important rather than the actual humidity itself. I don't think in the Chennai context, humidity is really that much of an issue.
If this was to do with the Middle East, sir?
Yes. So if you had a very dry kind of an environment, then maybe a humidifier makes sense. Or if you're in Delhi, for instance, or Hyderabad, which are very dry places. But in the Chennai context, I don't think so. And I don't think an AC in the room, you can't have an AC on the one hand blowing air at you and then have a humidifier in the other corner trying to throw in water as well. That doesn't make any sense. So no, I don't think so.
So what's your take on the relationship between orthoptics and evaporative dry eye? This is Ms. Sharanya Shanmugam.
Orthoptics and evaporative dry eye. I am not sure I truly understand the question, but the only link that I can think of is if there's something wrong with their ability to see clearly and therefore they're straining a lot and that affects their blink rate, then there could be an evaporative component. But while I don't understand the question correctly, maybe she had something else in mind, but this is the only way I can link orthoptics with an evaporative dry eye. If somebody constantly stares because they're not seeing clearly enough because of some orthoptic issue, and then their blink rate goes down because of that, then I can think that's the only way I can think of, unless I've misread the question. I'm sorry.
Apart from that, what I usually found was convergence insufficiency. Subjects had similar complaints. So maybe on that line.
Yes, so that is what in one of those slides where at the end where we showed the composite picture, the third picture from the top left, I think, if I'm not wrong, there was this lady sitting at a computer with her hands on her nose. So that is what I meant. So people with asthenopic symptoms will also complain of tiredness, brow ache, and in difficulty in reading and so on and so forth. So it's not very difficult to confuse those with a dry eye. And they're putting in as much tears as you can is not really going to help. So if they have an accommodative or convergence issue, which is setting up their symptoms, like you said, you have to treat those as well. And then see. So that, yes, but that is not really an evaporative dry eye in that sense. These are just symptoms that mimic a dry eye.
So the next question is for LASIK patients who undergo preliminary dry eye tests. In spite of them being normal pre-surgery, they develop dryness complaints later. Are there any specific tests you advise after surgery?
Not after surgery. Everybody after LASIK will have dry eye. So there's no question about that, because for your cutting corneal nerves, both when you create the flap and when you ablate the corneal stroma. So if you're doing a smile procedure, there's a little less of this because you're not really creating a flap as such. You're just making a 3 to 4 millimeter cut in the periphery. But even in a smile, you're ablating the stroma internally. So we are damaging nerves. But the smile theoretically produces less dryness than a LASIK procedure where you actually cut and open a flap. So everybody after LASIK will have dryness. There's no question at all. It lasts for anywhere between 3 to 6 months in the normal patient who has a healthy tear flow before. The trick here is to assess these patients well enough before surgery, because many of these people come to you for LASIK because they're not happy with their contact lenses. And long-term contact lens use is definitely a very significant risk factor for dry eye. We know that because of the nerves get attenuated and the feedback is disrupted. So you have to do your assessment before your LASIK. There's no point doing it after your LASIK. So before the LASIK, you have to make sure that the surface is healthy, that the tear volume, whatever you're doing, your tests are normal. If the tests are not normal, then you take time to bring it back to normalcy before you do the LASIK. If you operate on a dry eye which has not been adequately treated before surgery, and do a LASIK, then you will definitely have problems. And those problems don't need tests to pick up. You look at VI, you'll know there's problems. So the main thing is not to do a LASIK in a dry eye. So all the tests that we do before are to pick up these people. So you can put in a plug, you can put in some soft steroids, you can give them some cyclosporine, you can do adequate tear management, stop contact lenses, wait for 4 weeks, 6 weeks, and then do. The most important sign in the workup here again is ocular surface staining. So if I see ocular surface staining with borderline tear function and LASIK patients, I would 100% not do the LASIK, because the ocular surface staining is telling me that the surface is hurting from the lack of tears. So you do whatever it takes. It may take 3 months to even 6 months sometimes, but you don't do the LASIK. If you do the LASIK in this dry eye and then he comes to you with an epithelial breakdown and this and that, then it's a bit of a mess, because that will lead to DLK, it will lead to wrinkles and folds, and a lot of other problems will come in. So you definitely don't want to be in that ballpark at all.
Two questions combined. This is on contact lens for dry eye patients. For mild dry eye, what contact lenses would you advise? Is silicone hydrogel a good material? Your advice on that?
Yes, I think so, because I'm not a contact lens expert. I think you guys are. But from my limited understanding of this whole thing, so when my patients have problems with regular contact lens, many of them use monthly disposables for 12 years, 13 years. And then after that, I keep seeing them. And at some point down the course, I see that they're starting to develop some corneal vascularization. Their wearing time is coming down. They're developing some allergic issues. They're developing some dry eye issues. So then my protocol basically is to stop contact lens wear for 3 to 4 weeks, treat the surface, get everything back to normal, and then they're all happy after that. Then I tell them that if you go back to your regular lenses again, as long as you're using them once a week or twice a week for a party here or there, you'll still be all right. But if you want to go back to your 12 to 14-hour schedule with those lenses, everything will come right back at you, because your surface is now in exhaustion. So then I tell them that you have two choices. If you're really desperately keen on continuing long-term contact lens, and if you like the comfort of a soft lens, try a silicone hydrogel, because it's generally a low water content system, and then you might be able to get away with it. We don't know till we try. If you're still unhappy with that, then you have a second, less pleasant choice of an RGP lens. Many of our patients, we've been able to shift them comfortably to RGPs despite that borderline tear function, preventing them from wearing regular soft lenses. But that's an option. Somebody who's used soft lenses for 12 years is quite reluctant to take, honestly speaking. So they must be desperately motivated for lenses before they will consider that, because they're so used to the comfort of soft lenses. So my first choice is to stop, treat the surface, bring them back to baseline at about a month or 6 weeks, then offer them a silicone hydrogel. And if that fails, then I go on to an RGP. And if this also fails, then we talk about LASIK.
Ranjani, before you move to the last question, sir, you got a multiple call, sir. Is there any emergency or something?
No, it's okay. Don't worry. Not about.
Thank you, sir. Just 2 more questions to go.
Yes.
This one is from Ms. Anshika. Please ask the secondary dry eye from recurrent allergic conjunctivitis and chronic dry eye postpartum, what would be the line of treatment?
Chronic dry eye what? The second part of the question? Allergic conjunctivitis? Postpartum. Is it? Wow. Postpartum, I'm not really sure how relevant significant dry, unless she has seen somebody particularly like that, because you don't generally get dry eye postpartum. You can get it with chronic allergic conjunctivitis. Basically, that is because the allergic conjunctivitis hurts the conjunctiva, and once the conjunctiva is damaged, the tear secreting cells which are present in the conjunctiva, the goblet cells and the other small minor like mucus glands, minor tear secretory glands get affected, and therefore you have a dry eye. So if you can see these people early in the course of the disease, then you manage the allergic conjunctivitis adequately with whatever you need to do with steroids or whatever, and try and prevent the damage from occurring. Let us assume somebody comes to you in the burnt out stage of the allergic conjunctivitis, in the end stage where already everything has happened, and then you're left with a dry eye because of the extensive damage to the conj. Then you basically treat them with, these are basically more of aqueous and mucus deficient dry eyes, not evaporative dry eyes, because the lids tend to be better. So here we have to give them tear substitutes, which is the aqueous replacement component, and you may want to use some mucus secretagogues. Like I said, we only have rabemipide in India. Diclofenac has not yet come in. Maybe in another year or two we'll get it. So we can use a combination of these to manage that. The postpartum patient, to my knowledge, I have not seen anybody post-pregnancy developing a dry eye. Sometimes you get people who have it in the post-menopausal stage where they're taking some hormone replacement therapy after menopause to counter the menopausal symptoms. These are heavily progesterone-based treatments. So these people can have a dry eye. But in a young 25, 30-year-old who's delivered a baby, I have not come across dry eye, and I cannot think of a mechanism by which that can cause it. There'll be some temporary changes on the ocular surface during pregnancy, which all of you know, particularly contact lens wear and all that will become uncomfortable because they have corneal hydrational issues and contour changes and so on and so forth. But these are all temporary. These are because of the hormonal elevations that happen in the system during pregnancy. They will all get better once the baby is delivered.
So the last question by Mr. Arul, will hydration improve dry eye patients, the correlation, and how far does it correlate?
I assume you're talking about systemic hydration. We generally advise people with dryness to take 6 to 8 tumblers of water a day, but then we tell that to everybody, you need that much of water in the system. I don't think we can, if you're asking for a point-to-point scientific correlation saying I took 4 tumblers of water, there is so much dryness, 6 tumblers, so much dryness, I don't think there is any. I think we know that if you're dehydrated, your eye will take part in the dehydration. And therefore, it is important for you to stay well hydrated, which is important even otherwise. I mean, from the system point of view, the body is 99% water, so you need to be hydrated, and the eye is part of that. So in a dry eye patient, the advice that we give them is to make sure you drink 6 to 8 tumblers of water a day, 2 to 3 liters of water a day. But that's the extent of the correlation. It's hard to be more scientific or more connected than that.
Right, sir. Thank you, sir. And I'm echoing a lot of people's messages which they have sent. Thank you for a one session. And we learned a lot besides dry eye over here. Thank you so much.
My pleasure. Thank you for having me, and have a wonderful rest of your Sunday. Bye-bye.